Welcome to NEDA's Excerpts from the Experts, 7-minute learning sessions with researchers and practitioners in the field of eating disorders and individuals who share their experiences and perspectives. I'm your host, Sarah Bowie-Keaton. This week, our guest is Dr. Kamryn Eddy. She is the co-director of the Eating Disorders Clinical and Research Program at Massachusetts General Hospital and an associate professor of psychology in the Department of Psychiatry at Harvard Medical School. She is a fellow of the Academy for Eating Disorders and past president of the Eating Disorders Research Society. Dr. Eddy focuses her research on the course and outcomes of restrictive eating disorders and innovative treatments for these conditions. Today, Dr. Eddy will be speaking about Avoidant Restrictive Food Intake Disorder, also known as ARFID. Dr. Eddy, thank you so much for being with us and taking the time to speak with us about this very important topic.
I'm glad to be here.
So what is ARFID?
So I'm glad to talk to you guys a little bit today about ARFID. So Avoidant Restrictive Food Intake Disorder, or ARFID, is really an eating disorder that's characterized by restriction in volume or variety of food intake. So essentially that means not eating enough in terms of volume or limiting the variety, having a pretty narrow range of foods that one's comfortable eating. People with ARFID will restrict intake for one or more reasons, and these can include things like sensory sensitivity. So that is being really sensitive to different tastes, textures, or the way that a food looks, having really strong reactions to those foods, and then in turn limiting what they're willing to eat. Or it could be due to a fear of aversive consequences. So that is being really scared that something negative is going to happen after eating. This could be things like being scared that you're going to choke on a food or have a negative reaction like vomiting in response to a food. And often that's based on having such a bad reaction with eating and then subsequently avoiding those particular foods. And then over time, that particular food becomes many particular foods. And then the third reason could be just having a lack of interest in eating or food. And so that is just kind of generally being less interested in eating or finding food to be less rewarding, and therefore then forgetting to eat or just stopping eating more quickly. So it is really different from the other eating disorders. So a lot of the more typical eating disorders that we think about, anorexia nervosa, bulimia nervosa, and even binge eating disorder, as well as some of the other eating disorders, are really characterized by body dissatisfaction, a drive for thinness, or even body image disturbance. In folks with avoidant restrictive food intake disorder, or ARFID, restrictive eating is really not driven by or related to weight and shape concerns. Instead, it's really due to one of these three key maintaining mechanisms. And so that does make it really different. And in fact, they can't be diagnosed at the same time. So somebody with ARFID does not have one of the eating disorders. They can have an anxiety disorder. They can have any other kind of comorbidity. And often ARFID does coexist with anxiety, depression, attention deficit hyperactivity disorder, or autism spectrum disorders. Any of those disorders could also be present. But the ARFID, the avoidant restrictive pattern of eating, really has its own life in folks with ARFID.
Interesting. It's one of the lesser known, I think, of the categories.
You're absolutely right. And it is a new diagnosis. So now it's about 10 years old, right? But it was introduced in DSM-5 for the first time. And what we found really interesting in our team is that even though it was a new diagnosis to us as clinicians, it certainly wasn't a new disorder. But actually, ARFID is a disorder that can cut across the lifespan. So people will often start the disorder early in life, and it will persist over time. But it certainly is true that for some people, this disorder will onset in adolescence, and it will even onset in adulthood. There are 4 definitional consequences of ARFID that go into the diagnosis. So in order for the ARFID type eating that we're talking about to be problematic, it has to be associated with some kind of a health consequence or a major psychosocial consequence. So let me kind of break that down for you. So the couple ways that we think about it for ARFID are that it could be associated with a significant weight loss or failure to meet nutritional needs. The weight loss could be any kind of weight loss, could be falling off of one's own growth curve in terms of weight or in terms of height trajectory. That's one possible way that ARFID could manifest. Another would be nutrition consequences, and this could be nutritional deficiencies. So, for example, sometimes people with ARFID type eating are not eating fruits or vegetables. So they might really be quite significantly under in terms of specific vitamins that they might need. Others with an ARFID presentation may not be eating proteins, for example, and then they're really low in protein. So nutrition deficiencies is another type of health consequence for folks with ARFID. Another would be that they're also having trouble really taking in enough calories. And this, again, could result in weight loss, but it could be that they're not able to take in food in order to keep their calories up. And so then they're relying on nutrition supplements. They may be tube fed, or they may be using high calorie beverages, for example, nutrition supplements to keep their weight up. The fourth major sort of health consequence is really an emotional health consequence. And so this is one that we think about as psychosocial impairment. So for folks with ARFID type eating, they could be missing out on really important things in their lives. Some of these, for example, could be not being able to go to parties or go out for dinner. Others could be that they're sort of not able to get involved in relationships because eating is such a major part of life. What I would really want to underscore too is that ARFID is a really heterogeneous illness. So it doesn't look any one way. People with ARFID can be low weight, they can be normal range weight, they can be overweight, they can be obese. Weight really is not definitional for ARFID. Some people will be low weight, but that certainly is not a defining criterion of ARFID.
What does treatment for ARFID look like, and what are some key takeaways for our listeners today?
Yeah, I'm really glad you asked. So there are a lot of treatment options for individuals with ARFID. These can include things like care with a mental health professional in the form of cognitive behavioral therapy, for example. It could include nutritional counseling. It could even be occupational therapy, as well as medical monitoring for most folks. The care plan in terms of what will make the most sense is really going to be based on the presentation of the patient as well as the acuity. So some individuals with ARFID, as I've shared, it's a really heterogeneous presentation. So some individuals with ARFID will require a higher level of care. So that is that they may benefit from being in a hospital-based setting, particularly if they're acutely starving. And often folks with ARFID have really been eating in this patterned way for quite a long time. So some folks will require for intervention. But in my program, we do work with folks in an outpatient setting. And the treatment that we've developed is called cognitive behavioral therapy for ARFID, or CBT-AR. And this is really a time-limited outpatient approach that's been modified to be used in higher levels of care as well. But it's a treatment that's appropriate for all types of ARFID, provided that folks are able to take in some food orally. And this is a treatment that can be delivered in an individual format or in a family-supported format. And the idea of treatment for ARFID, as you can imagine, is really that it's about interrupting the food restriction. And so again, we think about food restriction in ARFID as being restriction in the form of volume or variety. So either they're not taking enough in terms of volume, or they're really limited in the range or variety of foods that they're taking in. In our treatment, the principle is really volume before variety. So that is to say that if folks are under eating and they're underweight, first things first, we've got to help them to get back on track with regular eating and increasing the volume of what they're already eating before we can increase the range of what they're willing to take in. And so we do this really by helping folks to first increase the regularity of their eating, that is by eating by the clock. And then as they're taking in more and taking in enough to begin to gain weight, we help them work on variety if that's a key problem for them. One of the things that we know about folks with ARFID is that whatever it is that may have started the ARFID, whatever it is that may have led to the ARFID, at this point, they're restricting their intake. They're restricting the volume or variety or both. And that restriction in and of itself has a host of downstream consequences. So we've talked already a little bit about some of the medical consequences therein. It also has a host of psychosocial consequences. One of the psychosocial consequences is that when folks are under eating, they end up actually with limited opportunities for changing their eating. We also know that the medical consequences associated with undereating also feed back into the undereating itself. So some of the nutritional consequences, folks have lost weight, sometimes their appetite also decreases and they get fuller faster. That really does also feed back into being challenged around eating more. It makes it harder to eat more if you get full really quickly. Likewise, if you're having fewer opportunities for eating, you're eating less, and you're avoiding a lot of settings where people are eating a wider range of foods, or for example, your family now doesn't expect you to eat with them anymore, you also have limited opportunities for changing your eating. And so what we try to do in treatment is really increase the regularity of their eating, increase and sort of correct the nutrition deficiencies, including restoring weight if that's a problem for them, and then really helping them to get more practice with eating itself.
Well, thank you so much. And thank you for all of the good work that you're doing with your research. Sounds like you're seeing some real effective treatments.
It takes a lot of bravery to be ready to make change. And we've been able to see a lot of that in our work. So it's exciting.
It is exciting. Thank you so much for your time today.
Absolutely. Thanks, Sarah.
NEDA's mission is to support individuals and families affected by eating disorders and serve as a catalyst for prevention, cures, and access to quality care. NEDA offers programs and services designed to help you find the help and support you need. Whether you have been personally affected by an eating disorder or care about someone who has, recovery is possible, and we're here to support you.